السلام عليكم. سامعيني؟ اكتبوا إذا بالملاحظات إذا سامعيني أو لا. بسم الله الرحمن الرحيم. Today I will discuss some short cases on the Facebook, and I will show you the case, and in the comments you can write the correct answer according to the question asked. الحمد لله والصلاة والسلام على رسول الله الحمد وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. اللهم أخرجنا من ظلمات الوهم وأكرمنا بنور الفهم وافتح علينا بمعرفة العلم وسهل أخلاقنا بالحلم. اللهم ارزقني نعمة الإخلاص لوجهك الكريم بكل ما أقول وبكل ما أفعل. آمين ورب العالمين. Here this link, you can, after the lecture or after some time, you can open the link, fill the requirement, the name and the email, and you can obtain a certificate of attending that short cases discussion. Let us start with the first case. Here you can take 10 to 20 seconds and see what you are seeing in this chest X-ray. This patient is a symptomatic patient. What do you think? You can answer in the comments, please. What do you think? What you see in this chest X-ray, someone Hisham is said it is right-sided aortic arch. Okay. The voice, it is okay or not? As we see here in this chest X-ray, we see an impression on the right side of the trachea, as we see here, and that impression from the aortic arch, and there is no aortic arch on the left side, and this is a normal, sometimes it is considered a normal variant. It is right-sided aortic arch, and we have three types. We have the mirror type aortic arch and we have the aberrant left subclavian, and it is depend on the book you have which it is more common. Okay, we move to the second case. What do you think of this case? What do you think in this case? Take some 10 to 20 seconds and see what is the in this case. Someone right coarctation of the aorta, right aortic arch, and aberrant subclavian artery. This is the correct answer. Right aortic arch, and this is the, and as we see here, this is the superior vena cava, and this is the right aortic arch, and this is the aberrant subclavian left artery, and this is the right answer. And we can move to the third case. Take 10 to 20 seconds and see the case and write your answer in the comments. What is your answer? Someone said it is esophageal atresia with TE fistula. You can hear my voice. Someone said it is no voice. As we see here, we have the coiled NG tube in the upper esophagus here, and the upper esophagus with some dilatation. And as you see here, this indicates that it is esophageal atresia. And also we see some gas in the bowel and the stomach, and indicating that the atresia, the esophagus, it is connecting to the airway. So this is a tracheoesophageal fistula. What is the type here in this esophageal atresia with the tracheoesophageal fistula? Which type? Can you write in the comments what the type? of this case. What is the type? Here, as we see here in this sketch, this is the esophageal atresia as we see here, and also we have the esophagus. It is fistulated with the trachea, and this is the type C, and it is the most common type. We can move to the third case. This patient with cough and some immune compromised patient. What do you see here in this chest X-ray? Take about 10 to 20 seconds for seconds. What you see in this chest X-ray, someone said it is miliary TB. Miliary shadows noted on the chest X-ray and others said it is a miliary TB. So this case, as we see here in this chest X-ray, we have miliary shadows in both lungs distributed randomly in the upper and the upper mid lower zone, and it is one of the differential diagnoses is TB. It is not the classic for TB, but other differential diagnoses can be seen in this patient, in this pattern, miliary nodules, and what if the patient has carcinoma, which organ can give this appearance? Please write in the comments. If the patient has carcinoma, which organ can give to this appearance? Fungal is another differential diagnosis, but if the patient has carcinoma, which appearance can give this? Thyroid metastasis. Very good. This is the thyroid metastasis in this patient. Breast and lung carcinoma usually did not give the miliary pattern. The thyroid carcinoma, it is give the miliary pattern. TB, one of the, as we said, it is one of the differential diagnoses. And this is the CT scan of this patient. We see miliary TB, miliary nodules noted in both lungs, distributed randomly. And this patient has thyroid carcinoma, and these are metastases from the thyroid carcinoma. in our country, TB is the most likely to be the diagnosis. Well, this another patient, young patient. What do you think of this young patient? Please take 10 to 20 seconds and write your answer in the comment. Where you think the mass? In the lung or in the mediastinum? If it is in the mediastinum, which compartment most likely to be? They said it is mediastinal mass. One right anterior mediastinal mass, anterior mediastinal, posterior mediastinal mass, left side. Lymphoma, one of the differential diagnoses. Okay. Teratoma, one of the differential diagnoses. Yes. Okay. If it is anterior, it is anterior or posterior. Someone said it is anterior, someone said it is posterior. Why it is anterior and why it is posterior? Why it is anterior, why it is posterior? Anyone? Someone said anterior, why anterior? Nobody. Right, why anterior? No need to, you are radiologist, no need to take the lateral chest X-ray. And you should use the radiological sign to localize the mass. Someone said anterior hilum overlay sign. As we see here, the hilar shadow are seen within the mass. The hilar shadow are seen within the mass. So this is hilar overlay sign, and so the mass, it is not in the middle mediastinum. And here we see the paravertebral sign or paravertebral line. So the mass, it is not in the posterior mediastinum, and what is left in the compartment, it is anterior mediastinal mass. And there is another sign here. We see any mediastinal mass not reaching to the clavicle, as we see here, so it is located in the anterior compartment. If the mass, it is across the clavicle, and this is the cervicothoracic sign, and the mass, it is in the posterior location. So the mass, it is anterior mediastinal mass, as we said. This is the hilar overlay sign, and this is the paravertebral sign. So the mass, it is not in the middle mediastinum, not in the posterior mediastinum, so the mass, it is anterior. And we have differential diagnosis of 5 T's, as you know: thyroid, teratoma, lymphoma, and what? So the mass, it is not reaching. So the mass, it is anterior mass, and we have the CT scan of this patient, and the mass, it is merely cystic mass in the anterior mediastinum, more to the left, and some dots of calcification as we see here, and we see here with the mass and the merely cystic mass, and the mass, it is mature teratoma in this patient. We can move to the next case. What you see here, this is the patient, and take 10 to 20 seconds to see what you think of this patient has. Left brain abscess, someone right, ring enhancement with restrictive diffusion, cerebral abscess, okay. As we see in this patient, we have ring enhancement mass lesion in the left side of the region of thalamus and subthalamic region, and with some indentation on the left trigone. And what are the differential diagnoses of ring enhancing lesion? You can put on in one word. What is that one word or two words? What are the differential diagnoses? We can write, said it is magic doctor. So magic doctor is the mnemonic of the differential diagnosis of the ring enhancing mass, and as we see here, this is the ring enhancing mass lesion, and the cavity of the mass, it is restricted diffusion. With ADC, it is black, and this classic for abscess formation. This is a classic for abscess, ring enhancing, and the cavity or necrotic material in the lesion, it is restricted diffusion, and this is in the ADC, it is black, and this is a classic for abscess. We can move to the next case. Take 10 to 20 seconds for this patient. This is testicular ultrasound, and what you see in this patient, you can put spot diagnosis in this patient. Someone said with epididymitis, no, it is not epididymitis. Other differential diagnosis. What is the diagnosis in this patient? It is a classic appearance. Someone said it is duct ectasia. Okay. Someone cystic duct ectasia with epidermoid cyst. Okay, this patient, as you see here, this is, as we said, this is ultrasound for testis, and this is the mediastinum here, and mediastinum here, and mediastinum here, and this is the cystic mass. So this is a retitestis. It is a normal variant, or sometimes we call it duct ectasia, and it is can be associated with epididymal cyst, and this is multiloculated epididymal cyst, and this is a normal retitestis. It is a normal variant, and it is increased incidence of retitestis after vasectomy. So this is retitestis or duct ectasia with epididymal cyst. And here this is another small cyst in the testis. So this is retitestis with epididymal cyst. We can move to the next case. No need to give the history for this patient. What are the findings? Take 10 to 20 seconds for the diagnosis in this patient. Someone said it is acromioclavicular separation. Someone said dislocation, acromioclavicular dislocation, actinomycosis. Okay. So this patient has trauma, and you see that this is the clavicle and this is the acromion, this is the clavicle, distal clavicle, and this is the acromion here, and this is the separation here. So separation of the acromioclavicular joint, and also increased distance, and this is the coracoid here, and this is the clavicle here, and increased distance of the coracoclavicular area. Normally, what is the distance between the acromion and the clavicle, and what is the distance between the coracoid process and the clavicle normally? Normally, what is the distance and between the acromion and the clavicle, and what is the distance between the coracoid process and the clavicle? Normally, it is about 5 to 8 millimeter between the acromion and the clavicle, and about 10 to 12 millimeter between the coracoid process and the clavicle. So as we see here, there is increase. If we see, we should compare with the other side, and the other side, what we can do stress review, and the patient hold some weight on his hand, or we can do the CT scan. Okay, so this is the acromioclavicular dislocation with also we have soft tissue swelling in the supraclavicular region and around the coracoid, around the clavicle here. And this is the grading of the according to Rockwood classification, acromioclavicular injury, and we see this is almost fit with the type 3. We have the dislocation here and the separation of the coracoid and the clavicle, and this, it is most probably type 3. So the treatment of this patient, it is surgical. Type 1, type 2, it is treatment conservatively. Type 3, it is controversy about the treatment. Someone, it is a plus minus surgery, and type 4 to type 6, it is surgical treatment. So this is acromioclavicular injury with okay, the next case we have this patient. Take 10 to 20 seconds to see what is the diagnosis in this patient. What do you think of this patient? Has hernia? It is not answered. You should put what is the type of hernia. Hernia, it is not answered. It is not a correct answer. Someone said it is inguinal hernia, right? Inguinal hernia. Someone, it is said indirect right inguinal hernia with bowel and omentum. This is the correct answer. Is there any hernia on the left side? Is there a hernia on the left side? Okay, let us see. Someone said it is bilateral inguinal hernia. Okay, let us see. This is, as you said, this is inguinal hernia, and once it is in the scrotum, and it is indirect inguinal hernia, you have the fat here, and you have the bowel, the small bowel here, small bowel and fat, and there is another small hernia on the left side. Okay. This is bilateral inguinal hernia. This is left side inguinal hernia. And this is the big one, right side inguinal hernia with the omentum and the bowel. Okay, very good from all of you. Let us move to the next case. It is simple. And what you see, here in this next case, what is the sign here? You can write the sign, the name of the sign here. Dense MCA, middle left dense middle cerebral sign. Hyperdense vessel sign. You should specify the name of the vessel and middle. It is a middle cerebral artery. Hyperdense sign. It is middle cerebral artery hyperdense sign, and this indicating there is an impending infarction in the territory of the middle cerebral artery, and this is the hyperdense middle cerebral artery sign, as we see here, and this is a clot in the, or thrombosis in the artery itself, and we see before a few hours before the infarction developed, and this is the sometimes indication of the treatment to give the patient intra-arterial or streptokinase treatment before the developed the infarction. Okay, very good. This patient status post-injury, and what you see in this patient, It is a spot diagnosis. Someone write avulsion from the anterior inferior iliac spine, rectus muscle, tag Shafi, avulsion fracture. So this patient has, as you see here, this is the avulsion fracture, and this is the avulsion fracture from the anterior inferior iliac spine, anterior inferior iliac spine, and this the four rectus muscle. So what is the muscle attachment in the greater trochanter here? Can you remember the muscle attachment in the greater trochanter? This is inferior, not superior. This is inferior iliac spine. Inferior, anterior, inferior iliac spine. And the attachment here of the rectus muscle. And here the attachment in the greater trochanter. Which muscle attached to the greater trochanter? Anybody can remember the muscle attached to the greater trochanter? Gluteus muscle. Okay, very good. Gluteus muscle. Okay. Which muscle attached to the ischium here? This is the hamstring muscle, and attached to the anterior superior iliac spine. Which muscle? Anterior superior iliac spine. It started with letter S. Anterior superior iliac spine. Anterior superior iliac spine started with letter S. Sartorius, it is good, very good. This is the sartorius muscle attachment here, and here it is the hamstring muscle, and to the pubic it is adductor muscle, and to the iliac crest the abdominal muscle. So these are the muscle attachment, and here the ischial tuberosity hamstring muscle, as we see here. Gluteal muscle to the greater trochanter, inferior iliac spine, anterior inferior iliac spine, it is rectus femoris, pubic symphysis, adductor group, and iliac crest abdominal muscle, and superior iliac spine, it is the sartorius muscle, and the lesser trochanter, it is iliopsoas muscle. Very good, all of you. This patient spot diagnosis, take 10 to 20 seconds for the diagnosis and see what is the diagnosis. Anybody write anything? What is the spot diagnosis of this patient? Someone write left adrenal adenoma, but someone write good answer. It is left adrenal adenoma lipid rich type. This is the good answer of this patient. As we see here, this is the T1 in phase sequence, and this is the T1 out phase of sequence, and we see here the adrenal gland in the in phase and the adrenal gland in the out phase, and it is drop its signal, and this is a classic for lipid rich adrenal adenoma, and there is no further treatment or investigation for this patient. How we know or differentiate between in phase sequence and out phase sequence? What is how we can differentiate? If it is in this patient, it is written this is T1 in phase and this is T1 out phase or opposed phase. What is how we can differentiate if it is not written on this image? Okay, what you see, how we can differentiate between the in phase sequence and the out phase sequence? What is the looking for? Okay, it is Indian ink artifact. This is the Indian ink Indian ink artifact. Very good. It is Indian ink, and we see black line around between the fat and the muscle. This is the Indian ink artifact. Very good. Okay, this case, this patient with a productive cough, and what you see here, take 10 to 20 seconds for the diagnosis. What you see here, in this chest X-ray, what you see, someone bites right-sided cystic bronchiectasis, left bronchiectasis, basal, left bronchiectasis, basal. Sorry, it is left side. Okay, very good, Muhammad. Left-sided cystic bronchiectasis. Where it is located? Where it is located? Someone write in the left lower lobe cystic bronchiectasis. You should you are a radiologist, you should try to use the signs and location for location of the lesion if it is not given all the study. As we see here, we have cystic changes involving the left lower lobe, causing silhouetting with the left hemidiaphragm. Some of the cysts have air fluid level here, as we see here, air fluid level, and some of the cystic changes. So cystic with air fluid level. The left side of the cardiac border is not well seen also, so some involvement of the lingula, it is noted in this patient. So we have cystic bronchitis involving the left lower lobe and with some loss of volume, and involving the lingula. Why some loss of volume? Because the heart and the mediastinal structure are little bit shifted to the left side. We have 3 types or 4 types of bronchitis, and we have as we said in this patient, we have the cystic bronchitis, and we have the varicose bronchitis, and appear as beaded appearance, as we see here, and we have the cylindrical bronchitis, and there is one type of bronchitis. Anyone remember that type? There is another type of bronchitis not written here in this sketch. Anyone remember of that type of bronchitis? Anyone remember that type? I give you a hint. It is associated with fibrosis. Anyone remember that type of that bronchitis? It is traction bronchitis. It is traction bronchitis attached to the associated with fibrosis of the lung, like in idiopathic pulmonary fibrosis or any other fibrotic changes in the lung, whatever the cause. So we have the cystic, varicose, cylindrical, and the traction bronchitis. Okay. We can move to the next case. Take 10 to 20 seconds to reach the diagnosis. What is the diagnosis here? What is the diagnosis? It is vertebra plana. Very good. Vertebra plana, vertebra plana, vertebra plana. Very good. It is vertebra plana. Okay. If it's this child, what is the most common cause in this child of the vertebra plana? If it is a child Okay, someone with eosinophilic granuloma. Okay, eosinophilic granuloma. Okay, if it is child, it is the most common cause, it is the eosinophilic granuloma. Okay, if it is adult, what is the differential diagnosis? What are the differential diagnoses if it is adult? We have a lot of differential diagnoses. Can be metastasis, can be due to leukemia, lymphoma, infection. Okay, so this is, as you see here, lateral lumbar spine of this patient, and we have the vertebra plana in this lateral spine X-ray. And this is child, and the most common cause in children, it is Langerhans histiocytosis or eosinophilic granuloma. Thank you. Very good, all of you. We can move to the maybe the last case. So this is the our last case in this tutorial. Take 10 to 20 seconds for the to see, and here I put a link. As you see, I put a link here. That link, you can open the link and fill the requirement, the email and the name, and you can obtain a certificate of attendance of this discussion tutorial, and you can see it or take it immediately in your email. So this is the, you can fill this, the email, your email, and you can fill your name, put your name, and you can take the certificate, come to your email immediately after the filling the required. Okay, so this case, it is a classic example of earlier disease. As we see here, multiple enchondromas involving most of the metacarpal and the phalanges, and you see expansion, and you see sclerosis, and you see industrial scalloping. So these are the characteristic findings of this patient. So this is earlier disease, and the most common complication is, what is the most common complication of this disease? We are afraid of chondrosarcoma. We are afraid of chondrosarcoma, and as a complication of earlier disease. And this is, as you see here, this is a child, because the epiphysis, it is not united, it is still, and the chondrosarcoma developed at the for decade of this patient at 40 years of age. So this is an earlier disease with, as it is, multiple inchondroma, bony expansion, sclerosis, and industrial scalloping, as we see in this example. And as I said, this is the, you can fill the attached form, open the attached form, and fill your name and your email to receive the certificate of attendance. Okay, thank you very much all of you for attendance, and hoping to see you inshallah soon in another webinar discussion. Okay, all of you open the link before I closed. Please take the link and fill the requirement, your name and email to receive the certificate. All of you open the link before I close. Okay, thank you. Thanks all of you for attendance, and hoping to see you soon إن شاء الله. شكرا على حضوركم، وفي أمان الله، وتصبحوا على خير إن شاء الله.